better. Good morning, everyone. Thank you for being here. I am Bridget Picou. I am a nurse by trade. I used to work here in the Valley. I still do work here in the Valley. I now work for an organization called the Wall Project, where we focus on women and girls living with and vulnerable to HIV. I am also an advocate and a woman living with HIV. And so this conference is really important to me because it meets me at all of those intersections. And so if you are here, you are meant to be here. And if you are here, I'm grateful for your presence. So a round of applause for yourselves. Yes. Who was here last year? I love it. Magic. All right. We have a pretty tight schedule this year. We're losing an hour. And so I'm going to try to keep us moving. And so if the volunteers are nudging you or if I'm nudging you, it's not because we're rushing you, it's because we want to be on time. All right. A couple things that I want to go over housekeeping wise and just intention wise, right? So what I would ask is for both your attention to the speakers and the presentations, but I'm also going to ask for your intention, right? And being here in this space and taking something with you. So what I would like for you to take home with you is a new connection, a new lesson, something you never knew before. And I also want you to take home with you feeling seen and recognizing that whether you are a person living with HIV or you are here supporting someone living with HIV, we are all in this together and everyone's presence matters and makes a difference. All right? Okay. So the restrooms are out the door, ladies. Are to the right, men's are to the left. Take your bio breaks as you need. We will have lunch served later on. I'm going to ask that you collect your lunch and then come back in here because we have a lunch presentation for you as well. I want to start also and not miss it. I'm going to do a land acknowledgement. I'm going to have to read it. And I'm going to do it on my phone because I can't keep up with paper. So stand by. Okay, so we are meeting today on the traditional territory and current ancestral lands and the homes of the Agua Caliente Band of Coahuila Indians. Did I say that right? All right. A federally recognized Native American tribe based in Palm Springs. The tribe is steward to more than 3,100 acres of ancestral land in the cities of Palm Springs, Cathedral City, and Rancho Mirage, as well as certain portions of unincorporated Riverside County that compromises the Agua Caliente Indian Reservation. We recognize, honor, and pay respect to them as the traditional land stewards of the land and water on which we now present, and we offer them honor. It's really important to, especially in these times, to acknowledge ancestors, to acknowledge spaces that people belong in, because we all belong in all spaces. Throughout the conference, you will hear us refer to women. When I say women, I mean women across the gender spectrum, period. A rose is a rose and a woman is a woman. Got it? So we're going to be respectful of that. Sorry, my phone. Understanding that not all folks have the same experience and not all folks have the same access to everyone and to be in all types of spaces. We're going to be respectful. We're going to, hopefully, I can count on you to give people grace, right? Not everybody knows the proper words to use. Not everybody knows the proper language to use. So I'm going to ask that you give folks grace if they mess up, but I'm also going to ask for the folks who mess up to take accountability for messing up, because that's how we fix things and move forward. So grace and accountability. Any questions on that? All right. Sometimes listening to information, basically hearing your life being talked about gets a little heavy, right? Even if it's not directly you as a person, it may be that you're living with HIV and it feels a little heavy. Should that happen, please find one of us. Our volunteers are in the shirts. Find us so that we can help support you. This is not supposed to be a heavy day. It's supposed to be a day of celebration and a day of togetherness and a day of learning. So if it starts to feel that way, please let me know so that I can do what I can Okay. All right. When you came in, you got a bingo card, yes? So as you finish the bingo card, please bring it to me. I have a ticket for you. You should have also gotten a ticket for just showing up and being here. So if you don't have a raffle ticket for just walking through the door, please see me for that. And then also on your seats, along with your programs, there is a survey. The survey is important. This is our second year doing this. Yay! The surveys matter for how we are doing, what kind of job I'm doing, so that I can try to improve upon this every year. So there's also a little ticket attached to that. So that's an additional. So there's 3 raffle opportunities. I have things you might like, things you might want. So please make sure you visit the vendors and get your bingo card filled out, and make sure you turn in your survey. For this moment right now, let's see, what am I gonna do? Who's wearing pink today? Stand up if you're wearing pink, or a shade of pink. That counts as a shade of pink. That counts as a shade of pink. All right, give me a number between, Anya, come here for a sec. I'm gonna whisper it to you so they know I'm not cheating. Give me a number between 1 and 50. 35. You're the closest. So, on this table over here, there are some earrings. So you get to pick a pair of earrings, keep it for a significant other, or give it to someone in the room. You can. So help yourself to whatever pair you'd like. You can keep it for yourself, or give it to a significant other, or to someone in the room. So throughout the day, I'm gonna randomly do stuff like that, okay? So you need to be in the space and like ready to go so you can get you something, okay? All right. I do want to also take a moment and acknowledge. So I want to take a moment and acknowledge our partners, because this is absolutely not something that we can do alone. First and foremost, I do not do this by myself. The guys at HARP PS, if you have not met them, if you don't know them, please get to know them before you leave here. Raise your hands, guys. Chris is out here somewhere. Jim is helping with the volunteers. Please, please, please. These are the most amazing humans on the planet. Jeff is part of the reason, a big, huge part of the reason that I am the advocate that I am. And so, shout out, I love him to death. I'm not gonna go too far because I'll start crying. And then additionally, please, we would definitely need to clap it up for ViiV Healthcare, for Gilead Healthcare, and Sarah. We don't have a Thera rep here, but they're amazing people too. And then our community business partners, BIOS. Handling our AV today are the guys from Icon City. Efficient and Fly. And Merck as well. Yes, yes. Palm Tree Clinical, Bio and Palm Tree Clinical both have booths outside. Make sure that you visit them. And then I'm going to come back because I want to give everybody a proper attention and time. So I'm going to come back and list some more of our partners after this first presentation. We have a photographer here today. The amazing Chad's right there. He's taking my picture. So, because I recognize stigma is a thing, comfortability with where you are in your status is a thing. We will be very respectful. Chad will be taking pictures from the back of the room, so he will not be getting your faces. If you see him with the camera and you absolutely 100% don't want to be anywhere near a photo, please let him know we're respectful of that. There is a photo little selfie booth in the hallway. Please feel free to use that. At the end of the day, I will be deleting those pictures, so they will not end up on social media. This is your comfortable space, okay? And so if there is something that is making you feel uncomfortable, again, let me know. It's important to me. All right? So I think we are ready to get started. I'm almost on time. Shut your mouth. Okay. Our first presentation. So I met Cherie at a dinner. Yeah, at a dinner, and I was giving her a hard time about some data, and she allowed me to do that. And not only did she allow me to do that, she had answers and was welcoming and kind. She is so smart. Did I read somewhere that you are also a poet? Girl, stop. Okay. So I'm actually going to let her introduce herself as far as her work is concerned. But what I want you to know is that I think she's an amazing human being, and we are blessed to have her here. And so, Cherie, I'm going to turn it over to you.
Good morning, everyone. Really honored to be here. I look at it as a special privilege to be standing in front of you today. My name is Cherie Graham. I am a pharmacist by training. In my capacity at Gilead, I am a medical scientist. And so what that means is I effectively communicate a lot of clinical and scientific information, mainly to providers and clinicians.
I messed up. Sorry, y'all. I messed up. As the speakers come up, I'll just make this general announcement, y'all, and my apologies. Let's make sure the guys are ready with your deck. So that's my bad. My bad, y'all. And are you guys ready? Okay, we're good. All right, thank you. Sorry.
Okay, we're good. Yeah, so I live in San Diego now. I'm actually from the East Coast, though. And so it's a little warm up here. As I drove up, I was noticing the degree slowly increasing. Luckily, I was dressed for it. But at any rate, I know we have a room filled with a diverse audience, right? I know we have some advocates, we have some healthcare professionals, even if you don't technically prescribe medication. So I'm happy to be in your presence. And I believe we have some prescribers or clinicians in the audience as well. So this presentation is designed to be all encompassing. And so hopefully everyone will be able to take something away today per Bridget's direction and guidance. So hopefully I'll be able to help you accomplish that goal. Just as a preface, so my presentation is focusing on discussing sexual health and HIV impact on women. As Bridget stated, when I say women, I generally mean all women across the gender spectrum. You will notice some differences because we're looking at scientific data, and we know that it's imperfect in terms of correctly categorizing data based on sex assigned at birth or gender. So I'll try to point out some of those nuances as we go through the program. Other than that, though, we have a really intimate kind of audience and room, and I would love to, be a facilitator of discussion as well. So I'm going to ask you all some questions. So feel free to not be shy. I think Bridget did a great job of, wait for the mic. There are floating mics. Perfect.
Greens.
Otherwise, we don't capture it in our recording. You're not going to be physically on camera, but we need to have the actual questions passed through the mic so it goes through. Thank you.
All right, sounds good. Let's get started. Okay, so this is just a quick disclaimer. I have to go over this. I'm part of the medical affairs team. You may have met other Gilead colleagues who may be on the sales team, but our work is non-promotional. So there are no products mentioned in this, no specific drugs. So we won't be doing any type of promotional talk. That's not what this is. All right, so we know that in the US, when we think about the epidemic, the HIV epidemic in the populations that primarily get a lot of focus, it's usually men who have sex with men, right? And that's because here in the US, 70% of new diagnoses occur among men who have sex with men. But when we look at the pandemic globally, we see that over half of the world's population living with HIV are actually women, right? And so that's why I am bringing forth the experiences of women living with HIV within this presentation to highlight that population. I think it's quite striking when you look at the number of new transmissions each week globally among women, whereas that it's 4,000 every week, right? So clearly this is a population that needs more attention when it comes to HIV strategy and HIV care. When we look at the disproportionate rates among Black women specifically, we see that they represent just 13% of the population overall in the US, but account for over half of new diagnoses among US women. So this presentation, again, is going to focus on women, but it's also going to highlight Black and Latina women, as we know that those are the specific race and ethnicities among women where we see, again, that disproportionate impact of HIV. There's also a need to really understand the linkage to care with women who are recently diagnosed. And what I mean by that is when you look at the number of women, specifically Black women who are diagnosed late, it's among the highest among any race and ethnicity and gender at 21% are presenting with AIDS-defining illnesses, right? And so we know that this means that at this point, the disease has progressed such to a point that they're effectively not able to fight off these major infections. And again, here's a point where we call out some of the disparities with our transgender sisters who are Black, whereas 41% of them received an HIV diagnosis in 2022. And we know the percentage of transgender women within the US is very, very low. So when we talk about the impact of HIV on Black women, and we talked about some of the disparities that exist there, but really we're also getting to the meat of somewhat of why that is. This slide is not all encompassing to get to that, but it gives us some tidbits of what some of the underlying barriers may be, and we'll talk more specifically about what those barriers may be a little bit later in the presentation. But when we look at PrEP, right, we know PrEP is highly effective for all genders, right? But when we look at Black women, across the U.S. who are eligible for PrEP, meaning that they are sexually active and they have maybe other criteria to be eligible for PrEP, we see 2% are prescribed PrEP medications, right? So trying to understand better why that may be. And I'll pause for a moment before I get into some of the overarching theories of what is undergirding these disparities to hear about your experiences, and maybe as a provider or as a patient yourself or within your social circle. I think that's important to share our experiences among each other. One of the aspects I really want to point out is when you think about transmission among Black women specifically, 91% are attributed by heterosexual sexual contact, right? So there is this misconception, and I know this with my own social circle, and there's a lot of data to support this, right, about who HIV affects, right? And so a lot of Black women in my own social circle and patients and advocates that I've connected with, and some of the clinicians that I talk to frequently, don't perceive themselves as someone at risk. I will try to stay away from that word, but I think it's kind of fitting in for this specific example of someone who can acquire HIV, all right? And then further, there are many data that show about 2/3 of these acquisitions from heterosexual contact are from the woman's primary sexual partner. So what does this mean is your relationship status, right, is not an automatic predictor of your chance of acquiring HIV. Because you are in a monogamous relationship or you believe yourself to be in a monogamous relationship, that does not preclude you from being at a higher chance of acquiring HIV, right? So that's an important message, right? When we are, I think all of us in this room are really strong advocates of getting the knowledge out there. That's a really strong point, is that, there's empowerment in not necessarily depending on your partner's transparency regarding their status or what they're doing sexually, and you can have that empowerment for yourself. When we look at Latina people, we see similar disparities, right? So they represent about 19% of the US population, yet 32% of new diagnoses. There's a lot of barriers that exist with both of these populations. Some of them are similar. I think we see one kind of more distinct challenge with the Latina population sometimes is this cultural or language barrier to care, right? And so understanding that we need to have providers in clinics who mirror the community that that clinic serves in order to really be able to connect with folks, whether it's to provide prevention or ongoing HIV care. All right, I'm going to pause here. Question time. So in your experience, right, what are some of the common barriers that you have seen with engaging women, whether it's for HIV care or preventative care? In your own experience or as a clinician, what are you seeing in your community? Where? Oh, okay. Well, one here and then one in the front row.
Well, shout out to Bridget for organizing this, and this being the second year, because one of the things that I'm seeing is there's not a lot of services geared towards women in like HIV direct services. And I've worked in Lewis, San Bernardino County, LA County, and even in LA County, which is a larger area, EMA, or eligible metropolitan area, there were very few services for women living with HIV. And then just I think we're doing better with like the advertisement of PrEP and just HIV, like the medications and everything like that we see on TV. I don't know, is my mic still working?
It's on.
Okay. You know, a lot of it isn't geared towards women. Well, I think we're getting better, but it's mainly geared towards the gay or trans community. And then I just wanted to, this is a little bit off from the question, but the 91% of women who are contracting HIV from heterosexual men, like that term, I was going to say MSM, because I didn't know that statistic. I feel like what I notice in community as well, or in working in the field, is a lot of, one, we don't have straight male representation, and it's because of that stigma that it's a gay male's disease, but also sexuality is really fluid. And a lot of straight men, if I'm being honest, don't identify as gay when they might dibble or dabble a little bit. And that's what I'm noticing in the community, that's what's happening. And that's why a lot of women are becoming positive, because their men, straight men, are dibbling and dabbling. So.
Yeah, it's a great call out. Sexual identity doesn't necessarily correlate with sexual behavior in a lot of cases. So it's a wonderful call out. And we'll take one more here, and then we'll, yeah, one more here, and then we'll move on.
Well, the biggest barrier, I believe, is the stigma, you know, and not wanting to communicate. In our circles, we don't talk about it. Oh, okay. I'm loud, gosh. But in our circles, we just don't discuss it. I know for me, when I try to as a woman living with HIV, when I try to bring it up to people, I can start the conversation, but they cut it off real quick, you know, so it's a lot of stigma still, even 45 years later, you know, so I think that's one of the biggest barriers to women getting into services, especially in the Black and Latinx communities.
Yeah, thank you so much for sharing. And you'll see layers of both of the elements that you two mentioned in barriers in subsequent slides, but we're certainly on the right track with that. So when we look at new diagnoses by region, this is specifically among women, right? New diagnoses in 2022, it's the most recent data from the CDC. We see that there are, the darker the states is the higher number of new cases, to orient you to the map. And what we see is that the majority of new cases are coming from the Northeast, so DC and Maryland. I'm from Northern Virginia, so that is the area that I'm from. The South, where over 50% of Black people in the U.S. live. And then also Nevada, where they're in the larger these states too have large Latinx populations. Florida, Texas, Nevada, they all do as well, right? So that's where we're seeing the majority of new cases. And I mentioned earlier that I don't love the term risk or at risk or risky sex and behavior. It's been identified as a term that is stigmatizing. You talk about the importance of stigma, right? This is one of the reasons why I don't appreciate that term. One, because it's not always, usually not accurate in terms of describing one's sexual behavior. Simply having sex in and of itself is not risky, right? And in some cases, where you live determines what your risk for acquiring HIV actually is, right? You could be have exhibiting, one form of sexual behavior in a state where there are very few new diagnoses and acquisitions from people who are living there with uncontrolled virus. But if you have that same sexual behavior in another state where there's a higher number of people living with HIV that may not be suppressed, your chance of acquiring HIV is going to be significantly higher just based off of where you live. And so at Gilead, we sometimes call this phenomenon with HIV a zip code disease, right? And so it's important to recognize, one, for your advocate work or for clinicians to bring this point, right? If you're seeing people that are traveling frequently, maybe they're taking cruises or they're going on vacation to certain areas where the prevalence is higher, that's certainly a conversation that you can initiate in terms of what protection or what other sexual health conversations you may need to have, depending on what that movement looks like. Okay, so when we look at this concept of the continuum of care, this is really highlighted by what our we know that the federal situation is very dynamic right now. So all of this is caveat, asterisk, asterisk. But currently, there are still target goals in terms of how we get to ending the epidemic. And you see those categorized on the left-hand side. This data on the top left is specifically looking at where Black women are along this spectrum of continuum of care. So the goal is for everyone who is living with HIV, 95% to be aware of their status, 95% of those people to be linked to care, 95% of those people to remain engaged in care, and 95% of those people to be virally suppressed, right? You see what the current percentages are for Black women in the US. 90% are aware of their status. So this somewhat suggests that testing and awareness is happening, right? But we see a pretty significant drop off when it comes to linkage and engagement in care, right? We mentioned how stigma plays a role in this cascade. We mentioned how knowledge gaps play a role within this cascade as well. But the ultimate, end goal is viral suppression for people living with HIV. And we see that number is drastically lower than the goal as well. So work to be done, right? And we'll talk about some interventions and strategies that have been implemented to work towards these goals. So this is not a doom and gloom presentation. We'll get to some interventions that have been successful within this population as well. I'm going to switch gears a little bit to the sexual health portion of this conversation because, it's really important, regardless of what your status is, to have a well-rounded grasp on sexual health discussions, either with your provider, if you are a provider, or providing care in any capacity. This is really important to understand how to go about these conversations. And I think from a patient or advocate perspective, this will be helpful in, maybe initiating some of those conversations with either your providers or providing guidance to people who want to engage their provider in sexual health conversations. Unfortunately, a lot of subjects within sexual health are still very taboo. And so sometimes the onus is going to be on the patient to initiate these conversations, even though it shouldn't necessarily be that way. As a provider, I hope that you can look at this and say, this is something I can do differently. These are some different questions I can ask. These are some different considerations that I may want to factor into the sexual health conversations that I'm having with people, whether they're living with HIV or if they need or want HIV prevention services. I'm going to read this quote verbatim from the WHO organization of defining what sexual health is. I think it is pretty impactful and all encompassing of the different aspects of sexual health. It's not just about sex, right? So they say that sexual health is a state of physical, emotional, mental, and social well-being in relation to sexuality. It is not merely the absence of disease, dysfunction, or infirmity. Sexual health requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences free from coercion, discrimination, and violence. For sexual health to be attained and maintained, the sexual rights of all persons must be respected, protected, and fulfilled. Yeah. And here's more of a visual representation of that connection between sexual health and all the other overall health aspects of, everyone's health status, right? Sexual health is really inextricably linked with all of these different health components. When we look at romantic and sexual relationships, right? Your sexual health can affect your intimacy. If you're experiencing some type of dysfunction or dryness or whatever the case may be, that can affect your ability to have strong romantic and sexual relationships. Mental health. Again, if you're experiencing depression or anxiety, that can affect your ability to, have pleasurable sex as you typically would, right? And vice versa. If you're experiencing some difficulty with your sexual health, again, some type of dysfunction or irregularity, that can impact your mental health. Social health, substance use. I mean, this is a common topic within this community. But again, if you're using substances inappropriately, that can affect your sexual health and expose you to different types of STIs as well. And then the physical health impacts. There are multiple studies that have shown that chronic health conditions such as cardiovascular disease and diabetes can affect your sexual function, and we're more likely to experience some issues with your sexual function. And there are certainly physical benefits of sex. It's a physical activity, right? And so, again, all of these things are working together. So this is why sexual health is so important. It's not just about sex, because it impacts so many other factors of your overall health. And really, the conversation about sexual health needs to start with a culturally inclusive foundation, right? Because we can't build the trust to have sexual health conversations with individuals without addressing some of these common barriers, such as racism and transphobia and homophobia and stigma and violence, right? We have to address those prior to even opening up this conversation. And this concept of a status neutral HIV continuum of care really implores providers to, when they're going through this method of testing folks for HIV, that it's grounded again in this culturally inclusive care, but that regardless of what the outcome of the test is, that there is care and there is a need to engage folks either in preventative services or linking and continuing or re-engaging people in care if they are testing positive. Okay. So sexual health, it's everyone, regardless of your status, should be having sexual health conversations, right? For people living with HIV, perhaps this includes a conversation of what disclosure looks like, right? Having a conversation about the importance of you equals you, right? So we know that how empowering that message is. And those conversations can help facilitate and mitigate STI, other STI prevention methods, and also facilitate pleasure within that conversation. Everyone wants and desires to feel good in that experience, and having those conversations can help you put those pieces together in order to experience that pleasurable experience from having sex. And for people who need or want PrEP, of course, like initiating the conversation and really cultivating an environment to open up that conversation will be important, again, with kind of that overlapping goal of having healthy and safe and pleasurable sex. So we talked about some barriers to care, and they're similar to the barriers around having conversations for sexual health. I won't highlight some of the ones that we've already talked about, but I will just highlight bias in terms of from the HCP perspective. One of the common biases that I hear just in my work is the engagement with older individuals, right? So, you know, older individuals typically frequent their primary care physician more, but they often have less engagement in conversations around sexual health because the provider has a bias that because they're older, that they're not engaging in sexual activity as much and may not need that type of care or conversation. You kind of see it conversely with the younger generation as well. It's usually more on their side, though, where they don't necessarily feel comfortable disclosing what sexual activities and behaviors they may be engaging in because of oftentimes that generational gap or divide. But understanding that, you know, there are barriers on both sides and sometimes they overlap. So just taking stock of where you are and your comfortability with having this conversation, particularly if you're a provider, addressing what those biases may be. Because, you know, oftentimes we say kind of leave it at the door to be able to provide the best care possible for the individual sitting in front of you. In terms of, you know, a really solid framework of how to take a sexual history, this is from the goals, New York City Department of Health, STI kind of department. And this is a general framework for which they put together. And I'll just kind of highlight briefly in my last few minutes here, you know, the procession of this framework, give a preamble that emphasizes sexual health. So we talked about how sexual health is not just about sex. It's really about your overall health status and how your sexual health may be affecting those other parts of your life. Normalizing the conversation, talking to everyone about sexual health, regardless of how they present, regardless of what their age, gender, sexuality is. Setting that stage of normalcy. Many clinics now are starting to offer opt-out testing, so it doesn't feel like you're targeting a specific individual. Everyone should be tested if you're sexually active, and so giving people the opportunity to say, no, I don't want that, or otherwise it'll just be a part of your general kind of care and testing. Asking open-ended questions is really important. This gives you an opportunity to hear some of the patient's what are their concerns that you may not otherwise be aware of if you're asking more pointed questions, right? So allowing them to lead the conversation in terms of what body parts they're using, what are the genders of the individuals they're having sex with, things of that nature. Listening is obviously important because you can miss things if you're making assumptions, as we just talked about with some of those biases. Okay, and in terms of key questions, this is particularly for people living with HIV. So these are questions, again, if you're on the patient or advocate side, that you want to make sure that you're discussing. If you're not already aware of the answers to these questions, and then as providers, please take a look and make sure that you are covering. These are just some of the foundational aspects. It's not necessarily all inclusive, but obviously it's important to understand what, if folks are undetectable or not. If they're on therapy, if they're undetectable in communicating, the benefits of doing so. What do you know about you equals you, right? We know that empowering message, right? If you're undetectable, you cannot sexually transmit the virus. Understanding what your partner statuses are. If they're, it may be important for you to know if they're serodifferent, if they're not living with HIV. Other STI prevention methods, right? So there are other STIs aside from HIV. I know it's what we focus on primarily, but it's important to continuously evaluate what your protection level is for other STIs. Condom usage, we know variable efficacy, but can be important for prevention methods. Again, other STI testing as well. Okay. Bridget mentioned intersectionality, and I'm just circling back to this because all of the conversations that we have about sexual health, particularly with Black women, and I would even say Latinx women as well, really is undergirded by this concept of multiple factors of an individual, so multiple presentations. And so when people show up to you, it's not you have to consider all of those different factors that may be impacting their parts of life. So as a Black woman living with HIV, who may struggle with substance use, those are all different factors that affect how that person receives care in a lot of cases. And all of those things should be considered when they're coming into the clinic, because oftentimes they face discrimination for those different intersectionalities that make up who they are. Okay, we talked about some of these barriers, so for the sake of time, I'm gonna actually just skip past this slide, and maybe I'll cover 2 more slides and I'll come to a close here. But when we talk about the barriers to care, a lot of this, yes, it includes the stigma and the discrimination from the provider, but some of it also comes from the community distrust in providers, right? And there's a difference between, we talk about mistrust and we talk about distrust, right? Mistrust, I think, is more of a suspicion of, inappropriateness, or, you're a little sketchy of your provider. Distrust comes from personal experiences or community experiences. And when you think about marginalized populations, there are often real life situations which people experience that cause them to distrust their providers. And so this needs to be addressed not only from the health care system perspective, but also from a community level. I'm a pharmacist, I've been in the health as a healthcare provider for many years. And so I've been on both sides of the spectrum, but I can tell you that I've gone into clinics and sought care. And I'll tell you one specific situation. I went to an urgent care center. I had bronchitis. They saw on the x-ray, it was very objectively, you could see that I had bronchitis. It was coughing, all the things. And so I asked for medicine to help, cough suppression medicine to help me sleep at night, which would include an opioid, right? And so he's asking me all these questions about where I'm from, and I just relocated to this area where I'm from, what other medicine I take, all these things. And so he finally agrees to give me cough medicine. And then at the end, he tells me, please don't tell your friends I gave you this, right? So I hadn't disclosed to him that I was a pharmacist at that point, because I don't, I shouldn't have to, right? And I don't think that it's fair and it's appropriate to change the way you provide care just based off of someone else's occupation. And so I wanted to experience that situation from a very, transparent place. And that was the experience. And so I know firsthand, even though I am a provider, that happens. And I struggle with that at times too. And so a lot of people can't pull out, I'm a healthcare provider card, right? And so what do they do? But that is why, and I'll end here, is that to be cognizant of time, these spaces are really important to be able to address a lot of these concerns. And yeah, I'll end it here, but any last thoughts or comments about any of the information you heard, or anything that you want to highlight before we transition? Right here.
I'm from San Diego, and I get my care at UCSD, and I'm in charge of my care. I know the OBGYN department does not contact me. It's time for you to get a pap smear. It's time for this. But they sure do know how to send me, you need a flu vaccine. You need to get your COVID. No. So there's failure, and I'm not blaming anybody in here because you guys are advocates. This is above and beyond your scope. So I just got an email for the second OBGYN conference for next year because I contacted them this year. They failed. They had one little blip about HIV in there. They had nothing else. And I am ashamed. I will not tell anybody to go there. I'm an advocate 38 years, and I shouldn't have to advocate anymore. This should already be plugged in, and it's not. So education is the key here for anybody. Assume everybody you're going to have any kind of intercourse with is infected, and then you won't be as big of a risk. But if you just assume, oh, I'm in a relationship and they're monogamous with me, I can tell you, ladies and gentlemen, it's not true. It's not true. We want to believe it. It's not true. So you can only do you. You're only responsible for you. So if you're on the receiving end of any orifice, you need to be very careful, whether you're a man or a woman, trans, it doesn't matter anymore.
Yeah.
If you're engaging, watch out what who you're engaging with, because just assume everyone's infected.
Own your care. Own your care. We'll have one last comment here.
Hi, my name is Vivian, and I'm from the downtown Los Angeles area, working in South Central and East Los Angeles. What I see with my patients, and this is over 30 years of working in HIV, is we have a lot of turnover with providers. So we get the wonderful providers from UCLA, USC, and they do their 1 or 2 year sabbaticals or fellowships in our clinics, and then they leave. And so that creates a lot of chaos with the trust factor. We'll have someone come in, and then within maybe 15 months, they're on their way out. And that attachment is something really significant because they're opening up their whole stories. A lot of our patients are in and out of prison, the jail system. They're using heroin and fentanyl. I mean, we have everything going on in downtown Los Angeles. And so when I ask as a case manager, I now work with the Minority AIDS Project. They say, how long are you going to be here, Vivian? I may have moved around between APLA and Altamed, and now I'm at MAP, but I said, well, some of you have followed me around. I said, I'm still here. I came back, and I just try to encourage that I'm not going to go anywhere soon, and I want them to trust me because they open up their whole life, and you know everything about them, and then all of a sudden the providers are leaving, and so I encourage them to go organize, and we do a lot of education as a mental health provider. I go with your little list, about the questions that you need to ask so that they understand and your time is valuable. But they just want to push me out within 15 minutes, and I don't like that,
Thank you for sharing, Vivian. Appreciate it. Okay, I'm going to hand it over. I don't want to hold us up too much, but thank you all for your attention. I really appreciate the opportunity to be in front of you.
Everybody give it another warm. So a couple things I want to point out. To your point, when we talk about our vulnerability to acquiring HIV, right, and being aware of with whom we are spending our adult playtime, I prefer to rather than assuming everyone is infected, because infected is kind of a triggering word for some people, we can think of it as everyone is HIV possible, right? Because when you turn things around and you put them in a positive, it makes it less scary and you're more likely to approach it. So we assume everyone is HIV possible, right? And you're right though, right? We do have to make those assumptions because self-care is the best care. We cannot presume that someone else is going to take care of us. I would posit and maybe, think that many of us in this room ended up living this life, which is not a terrible life, right? But because we were with someone that we trusted, right? So everyone is HIV possible. And shout out to my clinician, he's in the room. Want to keep his head down? Keep his head down. So we are going to move into our next presentation. Again, like I said, we're moving pretty fast because we have a tight schedule. But please, again, feel free to take bio breaks if you need to grab something to drink or eat. No blood sugar dropping. I am a nurse, but I'm off duty today. So there will be no diabetic falling out, right? All right. So I'm going to introduce, first we're going to have a short presentation by one of my favorite people in the world. I've worked with her before and I love her to death. She's going to do a short presentation and then we'll move into a panel discussion, which will be, I think, pretty impactful. And so, Miriam, I've been trying not to read bios for folks, because it's really embarrassing to me when people read my bio. And so I will allow each presenter to kind of talk about what aspects of their work, titles, professional, what have you, that they want to on their own. But just like with Cherie, let me say, Jeff calls Miriam the stigma queen because her work centers around HIV stigma. I just call her a queen because I absolutely love her. She's so great. We're lucky to have her here. So Miriam, thank you.
Thank you so much, Bridget. When Bridget tells you to show up and give a presentation, you don't ask questions, you just show up and give a presentation. I love her so much. And I will be talking to you about HIV-related stigma. I firmly believe that you cannot talk about HIV without talking about stigma. It's a parallel epidemic. So I'm an assistant professor of research pediatrics at the University of Southern California, and I've been studying HIV for over 20 years, okay, and in different roles, but since 2021 as faculty at the Keck School of Medicine, okay? So this will be a little bit of an overlap from our last presentation, but let's do some epidemiology. So in 2022, about 38,000 people were diagnosed with HIV, and 30,000 of those were men, and 7,000 were among women. So if we break it down, if you looked at the graph on your right, you'll see that 70% of new infections are among women of color, Black women, Hispanic women. If we look at the left side of the graph, among men, if you add the first two graphs, over 70% of new infections are among men of color. So the epidemic is heavily concentrated in communities of color. Okay? So this is trends in HIV outcomes. We're talking about receiving care, retention and care, and viral suppression. So for every 100 African American person who was diagnosed with HIV in 2022, 74 received some care. 52 were retained in care, and 61 were virally suppressed. Among Hispanics and Latinos, 73 received some care, 55 were retained in care, 64 were virally suppressed. If we look at it and we compare this figure to all the way to the right, among whites, we can see that these outcomes are lower in people of color versus their white counterparts. So let's look at viral suppression. When we look at viral suppression among females, we can see that among African American females, Hispanic females, compared to white females, viral suppression is lower. Similarly in males, African American males, Hispanic Latino males, compared to white males, their viral suppression, likelihood of viral suppression is lower. So one of the drivers of these disparities is HIV-related stigma. You may be familiar with this book. In 1963, there was a book written called Notes on the Management of a Spoiled Identity by Irving Goffman. And he wrote about stigma in following ways. He said that it was an attribute. He's a Canadian sociologist. And he characterized stigma as an attribute or a characteristic that is deeply discrediting, disempowering, and one that prevents people from engaging normally in social settings, okay? Since then, other scholars have expanded this definition to mean feature or characteristic that goes against a social norm or a social unit, a devalued social identity, social spoilage, any type of labeling, stereotyping, separating, status loss, reproduction of social differences. When it comes to HIV, HIV-related stigma, as we all know in this room, is negative attitudes and beliefs about people living with HIV or perceived to be living with HIV. And there are many types of stigma. This is not an exhaustive list. We have perceived stigma, which is the knowledge that if you disclose your HIV status, you will be treated differently. We have anticipated stigma, which is the expectation that you will be treated differently if you disclose your HIV status. For instance, if you're obtaining care somewhere, you may not want to go because you may think that if you disclose, you'll be treated differently. We have enacted stigma, which is blatant acts of discrimination where you refused healthcare, let's say. You go see a dentist refuses to see you. That's enacted stigma. Intersectional stigma across different social identities, right? Someone who's living with HIV can be stigmatized for their HIV, for their race, for their ethnicity, for their neighborhood, for their socioeconomic status. So it's across different levels. And by far the most damaging form of stigma is internalized stigma. And I'll go into detail about what that means. So internalized stigma, HIV-related stigma, is particularly harmful. And what that means is that all the negative things that you hear about HIV and people with HIV, you begin to endorse those beliefs. You begin to include them into your self-definition and your self-concept. And that is extremely harmful because it has health-seeking consequences. Okay? So let's talk about gender identity, race, and HIV stigma. Women experience more stigma and more severe stigma than men do. Women, to this day, are labeled as vectors of HIV disease because they can pass on HIV to babies. Now, we know that if a woman is living with HIV, if she's in care, if she's taking antiretroviral medications, she gives birth, the child is given prophylactic medication, the chances of transmission to a baby, very, 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 very low. But despite of that, women are still labeled as vectors of disease. We see stigma among trans women, needless to say. Across every and any group, trans women experience the highest levels of stigma. And this stigma is intersectional, based on gender identity, sexual orientation, race, ethnicity. Okay? People of color experience more stigma than their white counterparts. This stigma is also intersectional, based on race, ethnicity, socioeconomic status, neighborhood. Men also experience stigma, okay? And it usually manifests as threats to masculinity, but we have also seen stigma directed from men who have sex with men not with HIV, discriminating against men who have sex with men living with HIV. So we see that as well. What does stigma look like? I think we're all familiar, but here's a list. Blaming, shaming, stereotyping, harassment, physical violence, rejection, excessive precautions when you go and obtain health care, people putting on gloves and goggles and protective gear. It still happens, even though we're 40 plus into the global pandemic, right? It still happens. Care refusal, indiscretion with HIV status, people disclosing your status to others without your informed consent. We see contact avoidance, physical distancing. In many different countries, Namibia, El Salvador, Chile, we've seen compulsory sterilization of women with HIV, meaning treatments were withheld in exchange for tubal ligation of women with HIV. So that has happened. We see it in employment, where people are demoted when their status becomes known. Is this legal? No. But does it happen? It does. We see it in housing, where if you show up with a voucher from an HIV specialty organization for housing, where you refuse housing because of your HIV. We see it in schools. There were instances of discrimination against children going to Tanzanian schools where they were asked to wear a red label on their uniforms to differentiate them from students without HIV. We've seen it in Nepal where children with HIV were not allowed to go to school with children without HIV. And so there were special schools for children with HIV in Nepal. Okay? We see it in health insurance where people with HIV are asked to pay higher copays for HIV, basic HIV medications. We see it in religious institutions. That's actually a billboard from a church outside in Alabama, I believe. It's a sign that says AIDS is a God's curse on a homosexual life. It was featured in a PBS documentary called AIDS in Black America. Okay? And these are the inflammatory, negative, horrific messages that drive the community underground. Not okay. Probably one of the most pervasive places where stigma takes place is in healthcare settings. Now, one thing said, in healthcare, it should be a place of safety. It should be a place where you should be honest about your medical grievances. But it's a very common place where stigma takes place. There was a study done by UNAIDS in 2017 across 19 different countries, and they found that 1 in 4 people living with HIV experience discrimination in healthcare. I think it's a gross understatement. I think it's a lot higher than that. So a couple of years ago, my colleagues and I did a study in which we recruited women of color living with HIV, Black women, Hispanic women, to critically reflect on their experiences with stigma through documentary photography, okay? And I want to share with you how women of color experience and make sense of stigma using some of the photographs that they submitted for this study. So we recruited them, trained them in a concept called photo voice, meaning expressing your voice through photography, and we asked them to think about stigma and bring those reflections to life through photography. The woman that submitted this photograph captioned it HIV stigma and decay. She said that she went to see a dentist, as we all do. But the dentist said that he could not see her because he doesn't see people with HIV. She wasn't told this right away. They made her wait in the waiting room for hours upon hours and then turned her away. Did this happen in 1981? No, just a few years back. So it's still happening. So as a result of this treatment, of this refusal, she did not return for dental care for 7 years. How many times a year are we supposed to see a dentist? Right? Imagine not going to see a dentist for 7 years. This woman was very ill. She had pneumonia, had gone to see her doctor. The doctor was flipping through her chart, saw her HIV status and her medical record, stood a few steps far away from her, stepped a few steps far away from her, put a pair of gloves on a stethoscope before applying it to her back to listen to her lungs from a distance. I was very happy to learn that she scolded the physician in question and said, "I'm not going to infect you just by being here." This woman captioned this photograph, "Pennies are more valuable than me." She said to me, pennies are not worth much in the real world. And that's how society makes us feel, that like we're not worth much because we live with this disease. Okay? She said, pay attention to one of the pennies relative to the other ones, the one that is tarnished. She said that's how society makes us feel, as though we're dirty and tarnished. Not in 1981, just a few years back, so it's still happening today. So, what's the impact of stigma? Quite dangerous. Feelings of shame, isolation, despair, needless to say, right? Reduced self-esteem. A plethora of mental health conditions. Depression, anxiety, PTSD, suicidal ideation, all of those things. Suboptimal adherence to antiretroviral medication. People who experience stigma are more likely not to take their medications as prescribed. Loss and reduction of social support networks. I cannot tell you how many people with HIV have told me, when I disclosed my status, I lost my tribe. I lost people. People no longer wanted to associate with me. Okay, so loss of social support. Lower levels of trust in physicians, of course. Healthcare system. If stigma is directed from the healthcare sector, people are going to be distrustful. They already are because of historical misconduct, and it's just further amplified. What about the impact of internalized stigma specifically? So as I said, internalized stigma is the endorsement of negative views about people with HIV, right? So reduced retention and care, poor adherence to antiretroviral medication, reduced viral suppression, poor engagement in care, missed clinic visit, and the list goes on and on and on. Wow, that's blurry. So just a couple of studies that we did recently. We looked at the association of internalized HIV stigma among majority African-American women or women of color, and we looked at the likelihood of disclosing their HIV to their children. We recruited 438 mothers, and prevalence of disclosure to their HIV status to their children was about 30%. And what we found was after accounting for age, marital status, years since HIV diagnosis, those who experience higher levels of internalized stigma were less likely to disclose their status to their children. Okay? Okay. So some more outcomes. So women of color experience higher levels of internalized stigma compared to other groups. Stigma, as I said, internalized stigma is intersectional, as I said. Those who report being unemployed or having low educational attainment or low retention in care report higher levels of internalized HIV stigma, which makes sense, right? We found that high levels of internalized stigma in women is associated with emotional reactions to research, so they're less likely to participate in research and to offer information on sensitive topics. We already know that people with HIV are underrepresented in research, so if they experience stigma, that's further amplified, okay? And of course, this may not come as such a surprise that over time, if people have been living with HIV for longer periods of time, their internalized stigma tends to decrease over time, which is encouraging. But someone who's, let's say, newly diagnosed, particularly vulnerable, right? They may experience higher levels of internalized stigma. So how can we reduce the harmful effects of internalized HIV stigma? Here's what the literature shows: providing emotional and instrumental support to people living with HIV. Emotional being a shoulder to cry on. Instrumental, maybe driving someone to their appointment or getting groceries for them. That helps people, reduces internalization of stigma, okay? We see personal mastery, your sense of control over your life. If you have high sense of control over your life, you are less likely to internalize stigma. Same thing with mindfulness, being present in the moment seems to be a protective factor, okay? Complementary integrative health, things like meditation, it has shown some promise in reducing the impact of internalized stigma. We also see that resilience building is important. I'm pretty sure everyone here is familiar with the concept of resilience. It's thriving despite of adverse life circumstances. So the higher your level of resilience, the less likely you are to be impacted by internalized stigma, okay? So just a little bit more about resilience. Things like mastery, things like resilience can be built with cognitive behavioral therapy, things that could be helpful. So resilience in particular promotes engagement in HIV health. It helps with adherence to antiretroviral medication. It's very helpful. It's a protective resource, okay? It improves psychological functioning. We found that. It buffers against trauma, against stigma, and mental health conditions. So the higher your level of resilience, the better off you are, in a nutshell, okay? So I want to just real quick focus on how important resilience is in women of color who are disproportionately impacted by the HIV epidemic, but also in experiences of stigma, right? So despite multiple adversities, women of color living with HIV do find ways to be resilient. And where does that all come from, right? Members of their village, people in their tribe, okay? family members who provide support, friends, peers, partners. Those folks can provide support, increasing the level of resilience in women of color, which then is protective against the dangers of stigma. Okay? And the single most important thing we can provide to the HIV community, including women of color living with HIV, is social support. Okay? So, moving forward, what can we do? It's really, really important for people to understand, and I'm not sure that they understand this, is the link between experiences of stigma and health outcomes. Maybe folks don't understand when they discriminate against someone with HIV, that can impact their well-being and health. So we need to make that link explicitly clear, okay? Peer-to-peer support, people living with HIV supporting others living with HIV. Let's say someone help someone living with HIV for 15, 20 years, providing support for someone who's newly diagnosed, okay? Involving people living with HIV in the programs that we design, right? Bridget and I have spoken about this, how important it is for people with HIV to take leadership roles in designing programs for HIV reduction, for stigma reduction and such, okay? Training and education of students of health professions. I'm talking about nurses, physicians, ancillary support staff. Everyone needs to be trained. They need to have trainings in medical schools and nursing schools in all of health professions so that folks can learn about this early on. Developing and enforcing HIV-related stigma reduction policies, academia, healthcare. There should be policies in place on how to reduce HIV stigma, but also to hold people accountable for when they do discriminate, okay? And needless to say, of course, any type of gender-affirming care, one that is culturally affirming, culturally sensitive, sexuality sensitive, can help reduce the impact of stigma, okay? That's all I have for you. Thank you.
All right, so we're going to give them an opportunity to switch over, be up on stage. And I'm going to invite the panelists up. And so this is one of those times when I'm going to remind you about intention, okay? The women that are going to come up have been living with HIV for varied amounts of times. They have varied background and experiences. But at the end of the day, we want to remember that it takes vulnerability to say out loud that I'm living with HIV. You just heard all about the stigma and how that impacts. And so, again, just be intentional with how you listen and absorb what they have to say. So we've already met Miriam. Miss Portia Dees has kindly agreed to come and join us. She's done a lot of work for a long, long time. I'll let her tell you how long in the community. And then you have Miss Benita Rivies. Hi. How you doing, honey? I haven't seen her yet. I'm just seeing her for the first time. It's good to see you, babe. And then Miss Kimberly Jones Gates. What's up? I had to do the whole name. So warm round of applause for them. Let's give them your attention and intention. Oh, I gotta get the makeup? Okay. I guess I can do it. I mean, I'm not greedy. I'm gonna go ahead and share.
All right, ladies, thank you so much for being here. I have a series of questions, and I will ask the question, and anyone can offer us an answer, okay? And your answers, your responses, your experiences are highly, highly valued, all right? Okay.
Tell everybody about a little bit about yourself when
Yes.
you came to the mic for the first time. Brief.
Okay.
Of course, you got a long list. Brief.
All right, ladies. So the first question that I have for you is, can you identify for us some of the types of stigma you have personally encountered.
Hello, everyone. My name is Benita. Yes, I'd like to answer that question. I love you, Bridget. I learned about my status in 2007. I've worked in healthcare for over 20 years. And when I found out my status, I experienced a lot of stigma in healthcare with healthcare professionals. Then at the time I found out my status when I went to go seek my own help at that time in the community in which I reside. So that means people knew me, right? I experienced stigma and my confidentiality was breached. So then that put me into a depression for about 12 years. So I lived silent for many, many years after that. 2007, we're in 2025 now. I think I started to even discuss my status maybe in 2015. I'm one of the ones who my daughter knows, but I never disclosed to my son. As of today, my son has not heard from my mouth my status.
And do you think stigma is one of the reasons why?
Absolutely.
Yeah.
Absolutely. My son is 32 and my daughter's 36 and I'm 56.
Thank you so much.
You did. Yes, it does. Amazing.
Thank you so much for sharing your experience. Anybody else want to? Yes, please.
Okay. So, hello everyone. My name is Portia, and I am. I'll just talk about I wear many hats, but I'll talk about the one that I want y'all to know. I really want y'all to know right now. I'm one of the founders and CEO of the Lifetime Survivors Network. We are a national network of people who've been living with HIV since birth or early childhood. Shameless plug. We literally just dropped our website on June 5th, which was National Long-Term Survivors Awareness Day. And thank you. It's the lifetimesurvivorsnetwork.org. Check it out. The pediatric timeline is my favorite part of it. It lets you guys know of our history within the HIV movement, since the 80s when it became a thing. So thank you, Bridget, for having me. I've experienced different types of stigmas, stigma in healthcare. As I got older, not in children, I received my health care from Children's Hospital Los Angeles for the first 21 years of my life. I don't remember experiencing any stigma there, but at Kaiser, I'm now at Kaiser, but when I got older, I experienced stigma in healthcare. The biggest one I want to talk about, though, and the first time I actually experienced stigma that I was actually introduced to was stigma within my family stigma. And ironically, it was not towards me, it was my mother. So witnessing the stigma that my mother received from my family members when I was little, as a kid. So I was born and raised in San Bernardino County. My mother was addicted to drugs and would be in and out of jail for drugs and the things that women do for drugs. And so I think that was, what was it? When you're experiencing two types of stigmas at once. Intersectional stigma. So I feel like she experienced intersectional stigma from different people in my family, particularly my grandma, for the HIV stigma, plus she was on drugs, so the stigma from being a drug addict. And so that was really hard. I think my grandma took me in and I was sheltered and spoiled and treated like a miracle baby. or whatever or whatnot. But my mom, my grandma blamed my mom, and I remember watching her like cuss my mom out. My grandma was my family's from Mississippi, so my grandma's one of them Southern Black women that don't say her words all the way right. Like instead of saying rich, she says rich, like that kind of thing. And so she cussed like a sailor, and every time my mom would try to come see me, I would have to witness my mom getting cussed out. She would throw like stuff at her, call her all kind of B words, hoes, so that was hurtful. And I just feel like, and I'll wrap it up because I could be long-winded. I just feel like my mom, like just watching that and watching what my mom went through, like if she would have been able to get the care, this was back in the 80s, there were no services for women living with HIV. Back then, still not really here in the IE, so thank you so much for doing this, Bridget, for us. And even when you're talking about substance use services, I don't know if there was Gibson House for women back in the day, but she got ostracized by my family, and she didn't receive the care that she needed, and she never got into care. She never got into care, and she passed away my junior year of high school, and I feel like she would still be here to this day.
If she had
was able-
access.
Yeah.
Yeah. What a powerful story. Thank you for sharing.
Thank you. Thank you for sharing, Portia. Hi, everyone. Firstly, thank you, Bridget. Someone said it earlier, when Bridget asks you or invites you, you come. So thank you, Bridget.
Who's sparing
Hi, my name is Kimberly. I'm a medical professional here in the desert for about 8 years now. I am a researcher. I'm also the Greater Palm Springs chapter president for the Association of Nurses in AIDS Care.
Yay.
And I'm also an advocate. The first time I experienced stigma was at my diagnosis. I remember going in, at the time I was seeking gender affirming care services, which wasn't as popular or affirming back then. So I went in and it was like a series of process. It was a long process to even get on hormones. And I remember the resident was like, I have something to tell you. And I was like, oh, okay. And it never crossed my mind that it could be anything dealing with HIV because I had only had 2 sexual experiences prior. Growing up in a Trinidadian household, my dad was a sheriff, so I wasn't really out there like that, so it never crossed my mind. So when the resident asked me if he could tell me what he had to tell me, he also said, I'm also going to bring in some of my teaching staff. So there was about 6 people in this room, mind you. And they proceeded to tell me that I was diagnosed or I had tested HIV positive, and I would just took it in, like I was just like, okay, and I was wanting to know like more about that, and they all just kind of looked at me, and each one of them was like, well, how do you feel? And I was like, well, right now I feel judged. I feel crowded in this little ass room. And then the resident asked the rest of them to leave. And then I was told, and I was made to believe that I couldn't transition, and work on viral suppression at the same time. Like I said, back then it was a lot different. So, he proceeds to tell me, well, which one is more important to you, living, virally suppressed or living as a woman? So at that time I chose obviously viral suppression. So I had to prolong my transition medically until I found an amazing place called Palm Springs, and I came out here and found my now, primary care provider and one of my greatest mentors. So that was the first time I had experienced, being stigmatized in a room full of, it was about 6 people.
In healthcare settings. It's very, very unfortunate and particularly alarming, right? Thank you so much for sharing your stories. The next part of that question is, in the previous session, I talked about internalized stigma, right? Like how much it changes your self-concept and your self-worth and so forth. So can you talk about how internalized stigma has impacted your own life, if it has? Okay? If you've internalized the stigma and how it has impacted your lives, okay?
Well, I feel like I just want to say real quick before I answer that question. I don't want to make my grandma sound like she was horrible either. Like, I loved my grandma. She found Children's Hospital for me. She's like part of she took care of me until I was 2 years old, and my aunt took legal guardianship of me. So she just, to my mom, was not great. But so let's see. I think when it comes to that question, one of the main things that's popping up in my head is the fact that I internalized that I was gonna die. So I was born in '86, and the doctors told me I had 5 years to live. So from the very beginning, I received that message. Then I'm watching my mom pass away from AIDS-related illnesses had a big effect on re-internalizing that. And then moving forward to when I experienced stigma, the first time I experienced stigma, aside from what I just mentioned with the family stigma that my mom experienced, but I remember the first time I experienced stigma was when I got into middle school and high school. When I started learning about sex or being interested in sex and dating. And because before at Children's Hospital, I was treated more so like just a person who had a terminal illness. Like other children in the allergy and immunology department, we all had different terminal illnesses. And so I was sheltered from the stigma in that sense until I got into middle school and high school and I started learning about sex and dating. And so that was the first time I remember experiencing stigma. And that was within learning about taking sexual health education classes in, I think I was in the 7th grade when I took my first sexual health education class. And then my social worker, when I was in the 6th grade, sat with me and talked to me about HIV for the first time. And it was very, very sex negative. It was very, very, like, this was before we knew U equals U. This was back in the day. And so, like, the pictures and stuff that they showed us was of people wasting away, dying. The messages that they were giving me were that, like, I couldn't really, not that if they were telling me how sex was, or how HIV was passed, pretty much through sex, through, it wasn't, how can I say this, sorry. So it wasn't like, I remember leaving the presentations thinking like, dang, I'm not gonna be able to have babies. I'm not gonna be able to have sex without using protection. I'm not gonna be able to have a normal, healthy, like, relationship, or let me not say healthy, pleasurable relationship. Like, so, and I remember being undetectable and when I graduated high school, but again, my mom passed away. And I'll wrap it up here. Sorry. I have a lot to share, so. So I remember being undetectable when I graduated high school. This was in 2005, but I did not know U equals U. Undetectable meant untransmittable. And my mom had just passed away. And I had remembered the message that my aunt had told me to be careful who I shared my business with. It was just like, she was like trying to prevent me from experiencing stigma. And I ended up sharing my business, my status with someone, the very first person that I dated in high school. and we broke up, and that person spread my business at the school, and so it went around the school like fire, like a wildfire. And so those were also the messages that I was getting from, like when it would come back to me. For example, like I ended up dating another person after that person, and they would come up to that person and be like, "Oh, why are you dating her? Like, you know, she has HIV, you can die, you know, so, or she, you know, you can die, she, you know, she has HIV." So it's just, that message sticks out to me. Like, everybody thought I was gonna die. I watched my mom die. I ended up thinking when I graduated high school that I was just gonna die. Even though I hadn't lived all that time, that's what I thought. And so what was said in the presentation resonated with me, because I actually did stop taking my medicine at that point. And so yeah, I internalized that. I also internalized the part, given that I still had people that wanted to date me, even though that they knew my status. It was also this experience that we didn't know what we could and could not do. And so like our sex was very like cautious. So like, you know, because they were scared, and I had to be understanding of that. Like, they're scared, they still want to date me, but, you know, so we have to use protection. We have to go get tested every 6 months. I was dating in high school, I was dating women. So I wasn't able to get head. We all grown in here, right? I wasn't able to receive head without a dental dam, which didn't feel good. One particular ex that I was with, like every time we would have sex, they would like inspect their fingers, like just to make sure they didn't have any cuts or anything on their fingers. Just because they were scared, you know, we didn't know U equals U at that time. And I internalized all of that to feeling like that I was kind of like this infected, dirty person, and that all like affected me. So, sorry. I'll stop right there.
Thank you for sharing that. I know that was thank you. Thank you. I just want to acknowledge, I didn't identify myself professionally. Today, just recently, I took a position with the county of Riverside, working in behavioral health, mental health. And this is the outcome. My education and how I chose to work on myself was behind me sitting in depression. And that was and recognizing my own internalized stigma. And so it moved me in a direction to better myself, to know that, you know what, it's more important that I love myself than being worried about people loving me. So today, I never would have guessed that I would be the woman that I am today versus where I came from. I realized that the internalized stigma, I was holding myself down. It wasn't the people that was judging me. It was me. It was because I was allowing that to happen. So it took all that years of therapy, years of sitting with myself, wondering why am I allowing what other people think of me to hurt me back. You know, they had heard it. And see, I'm someone who was married for 15 years. Right after I divorced my husband, I found out my status. You know, and I go figure. I didn't understand. You know, whenever I was notified of my status, I said, "Oh, well, that's a mistake. We're like another person. I've been married for 15 years." So, you know, I understood everything you were saying. I've been there. Been there. You telling my stigma is, you know, for me, it's what I thought of myself. It's what I thought
Your
of myself.
self-concept.
You know, so today, I have to be bluntly honest with you. I think it was one of the questions about how it's impacted daily and all that. And don't nobody qualify. You know, don't nobody qualify. But my self-love is through the roof. You know, and there's no amount of money that can buy that. You know, so it's okay. It's okay. It really is okay. And you like me or you don't. You know, you like me or you don't. And I love you anyway.
Yeah.
Anyway, in spite of.
Message.
In spite of.
What a powerful message. Thank you, Kimberly.
So I have a full circle story, but before that, my internalized stigma was based off of fear. I grew up in the 90s, so I saw shows like The Real World or Queer as Folk or, you know, Degrassi, who the representation of people living with HIV was always from a negative connotation. So I was just scared to, you know, come out even once I got virally suppressed. So I just kept that. And also, like, in my family, I had an uncle who passed away of AIDS in the 90s as well, and I know how Caribbean people talk. So when I grew up and I saw that, I was like, I can't tell my family. And then I started working in HIV, and I started getting, you know, the education and learning about it. And I remember I was testing and counseling people, but still I had never really came out. Like, I didn't come out about my status. And I was invited to, I was one of the first openly trans employees at the first organization I worked with out here in the desert. So they invited me to this gala to kind of just, you know, be representation and, you know, say a few things. And I remember we were at the sound check before the gala, and they were saying like, oh, you know, Kimberly, she does this with our patients, and she is living with HIV. And I remember seeing it on the prompter for the first time, and like, I had no idea that that was going to be announced in front of like thousands of people. And I remember panicking and calling, you know, my PCP, who, you know, I had now started working with, and being like, what the F? Like, I'm like outing myself in front of thousands of people. I was like, I can't do this. I'm freaking out. The producers of the event were like, well, we can change it if you want us to write it. And then I saw a beautiful Black nurse who was actually going before me in this gala. And she was talking about like her power and living with HIV and how, you know, it has changed her life, and she's done all these amazing things. And in that moment, I was like, I want to be her. I want to be her. Whoever this woman is a gift. And in your presentation, you mentioned seeing others, seeing the community, because that is when my life changed for the good. After that, when I went back I did say, as the teleprompter said it, I said it as that. And that was my first time coming out to that many people. And I remember going back to work with that power I felt of my story. And I remember the next time I got, and you know, someone who was newly diagnosed or someone I was testing, I remember opening up to them and being vulnerable, and I saw the impact it had, and I knew the power I then possessed. And that nurse was Bridget. It was through seeing the power that she had, that she still has, that she is amazing. It was through that made me realize my power. And that is when my internalized stigma kind of just washed away, because I knew I had a purpose. I knew I had power now. And that was my full circle story.
Thank you so much. What a powerful story. Thank you. Ladies, we have about 5 more minutes, and I really want to focus on what advice you would give other people with HIV who maybe are experiencing stigma and are affected by that. I know you've mentioned self-love, which is so incredibly important for all of us. But what sort of strategies and ideas do you want to offer other people living with HIV in the face of stigma?
My diagnosis changed my life. I can't fathom to you all the things I've been able to do, the doors that have opened for me, the people that I've gotten to work with. And it was me embracing, like I just said, that power, that purpose. And I've received so many, even now, I've received so many emails from patients, that lives that I've touched just by sharing who I am and, you know, what I care about and my passion for working with, working in HIV. So I would say embrace that, embrace who you are, embrace that diagnosis. At our last conference, there was a question and that went around that if there or when there is a cure, would you take it? And I think I was the first to answer, and I was like, no, this is who I am. HIV gave me my purpose, and at 30, well, I'll be 36 next week. At 36 years old, I never thought that I would be financially independent. I never thought I would have the tribe that I have, the people that I call my family, and even my actual family. I never thought that I'd have that in my life, especially me being a Black trans person. I never foresaw that. And, HIV really, before I was just existing, and now I'm actually living, and I love it.
Yeah, I would say pretty much the same thing that both ladies touched on. And that's just to dare to be different. I think once I made it through my whole falling out of care stage when I graduated high school, what saved my life was after I got out of the hospital. And, I was like, okay, I didn't die. I made it through this. I got to do what I got to do. I got to get back into care. And most importantly, I needed to get connected to the social connectedness piece is really key. I needed to get connected to other people with my same experience, so that I can see my only example was my mom who had passed away. So I needed to see other examples of people living with HIV who were thriving and having in relationships, having babies, who were born negative. So for me, when I got connected to, the first place I got connected to was the Consumer Advisory Board through AHF. And then from there, I got my very first job at FAP. I got connected to the Well Project. I got my first speaking engagement, and I started being able to, instead of keeping it all in and stuffing things, emotionally stuffing things, I got to tell my story and my mom's story in the way that I wanted to tell my story, and put some respect on our names and our experiences, and just dare to be different. Everybody in the world has a story, and nobody is going through any kind of trial or tribulation alone. There's somebody that's going through this same experience that you're going through. And it wasn't until I got connected into community that I realized, okay, that I have a purpose, and And so I just think, like she said, embrace it. Also, you equals you, and getting more educated on HIV helped a lot too. So once you equals you became a known fact, that literally changed it was a game changer for me and how I felt about myself and how I moved within the world. That's why, to be honest, I was having unprotected sex before you equals you, and just, not saying anything, but that's why I wasn't passing the virus. I can do this, I can do that, so I think just seeking knowledge, seeking that education, and getting connected to people with your same experience is the advice that I would give.
Thank you so much. I think, are we?
If Benita wants to give just
Yeah.
a little short.
Did you want to?
Absolutely. What I would say to that person is start with yourself. We can't start outside of ourselves. We have to start with ourselves. because for me, I always felt like people betrayed me anyway. So I had to start from within. And whenever I was able to start with myself and focus on myself and learn who I was and what my desires were, then I could go outside of myself. I had to get comfortable within my own skin first. How can I expect somebody else to get comfortable with me and understand me if I can't get comfortable with myself and understand myself? You know, so I really believe in starting within. That whenever you are faced with something challenging, start within.
Yeah. Excellent. Thank you.
Another huge round of applause. Thank you guys so much. Thank you. I genuinely wish we could have time for questions. We found it out. However, I don't think you guys would mind if people came up and talked to you, right? I didn't think so. First of all, let me say this. Y'all hear how they call me a bully? And said that I demanded that, and he made me cry? You see what they do me? It's all right. Thank you guys. So we're going to transition into, what happened? Did I hear something? Okay, we're going to transition into lunch, and so this is what I'm going to ask. Pick your lunch up, stretch, take a little break, chit chat. I would love if you could be back in this room by 5 after. I'll understand if you struggle a little bit, but we do have another presentation. You can bring your lunch in here and eat, okay? So don't feel like you have to sit and scarf your food down. And yeah, so let's shoot for 12:05. Back in this room. I hope that you are gaining and you've gained something up to this point. The energy in the room still feels really good. Once you eat, don't get sleepy and tired. We got some more to come. So I will see you all in a few minutes. If you have finished your bingo card and you would like your raffle ticket, come and see me. I'm going to sit right here, and I will give you your additional raffle ticket.
Welcome to our session on building power in her voice and amplifying women's journeys who are living with HIV. So we are improvising because what we found was that we had a number of our participants who were part of the Confessions podcast who were also in the audience. And so we thought it'd be very powerful for them to share about their experience being part of the Confessions podcast. So I'm Natalie Sanchez. I'm the director of UCLA Los Angeles Family AIDS Network, and joining me today is Elia Silveira. I'm the social work case manager at UCLA in the pediatric department. And so if we can have the women introduce themselves, their name, what season they were part of, and a little bit about themselves.
Hi, everybody. My name is Marilyn Ramos. I am in season 1 and season 4, and in the reunion. I currently was a peer navigator for a wonderful peer program, only peer program that worked with cisgender women of color in LA County. Unfortunately, our funding was not extended, so our peer program did end. But I'm still a peer navigator because I still get phone calls, texts, and I still work for free. So this is just something that I love to do, and this was thanks to the podcast that I'm able to be here and assist my my community and women that are infected or affected by HIV.
Hello, everyone. My name is Janisha Jones. I have been thriving with HIV for 18 years now. I currently am living in San Diego. I'm originally from Oakland, California. This is what y'all must be from the Bay too. Look, I know. So I am the aging and research coordinator over at Christie's Place. The reason why I did the podcast is because I wanted ladies to know that you are not alone. We are all going through this. HIV does not discriminate with race, sex, or anything. And to let the ladies know you're okay and that we're going to be okay as long as we all stick together.
Hello, everybody. My name is Veronica Nava. I grew up in Mexico, but now I live in San Diego. I'm a outreach and peer special outreach and I forgot my title because it's long. I work for Christie's Place, and I've been living with Positive for 10 years. I did season 3 of the podcast, and I encourage you to do it. It empowers you more, and once you do that, it's like the sky is the limit. It gives you opens the door. So I encourage you to do it.
Oh, I forgot to say what season. I was in season 5. Yes, season 5.
Hi, everybody. My name is Magdalena, and I've been living with HIV for 8 years. I'm from Mexico, but most of my life I lived here in San Diego. I do work at Christie's Place too. Ever since I was diagnosed, I encourage myself to educate myself, to advocate for myself and others. So, yeah, I've been working at Christie's Place too for years, actually. I'm early retention specialist, and that's where I hear about you guys. Well, actually, I did the book. I'm so sorry. I did the book at Christie's Place, Healing with Hope, 155. You guys have it on your. And so I'm in season 9, and yeah, like everybody's saying, the reason I speak about it, I'm sorry, is because I want everybody to know your status and talk about HIV. Let's end up with the stigma that is out there. The more we talk about it, the more we normalize speaking about it and remove the stigma. Know your status is the key. And thank you.
So a little bit about our podcast. Well, who in the room has listened to Confessions podcast? One loyal listener. We have one loyal listener. We're hoping that the rest of the room will be loyal listeners by the end of this. But our podcast is docuseries style, and so when we record, we do interview questions, usually done by Elia or one of the other team members. But we edit ourselves out because really the real star of every episode is the woman that's being interviewed. So their episode is considered their episode, their story. And so each one of them have their own episode, with the exception of Marilyn, who has 2 episodes and might have 3. But again, it's just so powerful and uplifting when you hear from the vast experience of women who are living with HIV. So I'll go back and forth between talking a little bit about the podcast and then asking questions. So we started the podcast in 2023, where we were releasing for National Latinx HIV/AIDS Awareness Day. So we started with the Latina season, and that was when Marilyn decided to be part of the podcasting experience. So I'm going to ask the question of your readiness to participate in a podcast, and what were your initial reactions and to participating? What encouraged you to participate in Confessions?
Readiness, none. I had previously not spoken about my diagnosis publicly at all. I think that it was just a few family members that knew, especially, my mom, my sister, my brother, my husband, and then whoever my mom told. But yeah. I talk about that in my podcast. You guys need to listen to that episode. And so I didn't feel ready at all. And Elia, she reached out to me and she's like, I know you're ready. And I said, no, I'm not. And she's like, yeah, you want to do this podcast? And I was like, no. And she's like, no, you're ready. Like, I feel you're ready. I know you were ready. And I was like, yeah, maybe I am ready. But the reason why I actually wanted to do it was because she said that it was confidential. I can change my name. I can be like anybody. I could be Beyonce on there or whatever. Yeah. And so she's like, we can even change the voice, the sound of your voice. You choose a different name. It's not video recorded. And I was like, okay. And then they are able also to edit out, if you mention like a city I live in the San Fernando Valley in LA County, so it's small. You think it's big, but it's not. And there's not a lot of people with my story or my name. And so, they're able to do that.
My mom's name is Marilyn.
Yeah. Oh, and there you go.
Yeah.
It definitely could have been her. So I felt safe to tell my story at that point where I was like, okay, I don't have to say it's me. I can share whoever I want to. I don't have to tell everybody that I did the podcast. But once I did it, I think that it was very liberating for me. I just was able to share I just sent it to people. I didn't even give them a heads up. I'm like, hey, here, listen to this. And then I had coworkers call me like, what did you do? Like, it's 7 a.m. and I'm crying. And so they really reached out and said, wow, like, I know you've been through a lot, but I didn't know the extent of how much you've been through. And so it was really eye-opening for me. It's been it's a healing process for me. And that's what it became. It was therapeutic. And I just, thank God and Elia and Natalie for this vision of women telling their story, because I would still be in my little cocoon at home, not wanting to step my foot into a conference or a group. I hated group, and things like that. So it's really opened a lot of doors for me.
For me, I do a lot of, speaking. I've done a lot of things, but for some reason, when I did this podcast, it was a different feeling. I was nervous. I don't know why, but because I've done these things before, but I was nervous. But after I did the podcast, I realized when I actually heard myself, because I had never heard myself after I've done public speakings or nothing. So to actually hear myself tell my story, and the part of the story that I included about my son, which is a touchy subject for me because I lost my son in 2020 to AIDS. He decided that he didn't want to live with it anymore. So it was a story I would tell to, people that I knew here and there, but to just nationally say that and to hear myself sharing it, it gave me a whole nother sense of empowerment. It lit a fire under me. I literally, when I was listening to it, I started crying because I didn't know that the podcast was even out until a client came into the office and was hugging me and telling me that they heard it and everything. And when I heard myself, and like I said, talking about my son, I literally could hear my son saying to me, thank you, Mom, because he was not open about his status, but he was my biggest supporter with all the stuff that I do in the HIV community. So it gave me a whole nother fire. And so if I would not have done the podcast, I probably still would be just telling people about my son here and there. But now I'm ready to tell everybody, because my story might actually be happening to someone else, or it might have happened to someone else. And they don't know how to deal with losing their child because they have HIV themselves. My son was diagnosed in his senior year of high school. He didn't get it from me. And that is something that, I want people to know. Talk to your kids. I talked to my son, but, unfortunately, he still wind up getting HIV. Our kids are very important. Talk to them, because you never know, what's going on, what they're doing, because teenagers, young adults, they're going to do what they're going to do. But us as parents, at least let them know, hey, you're at risk, especially if you're living with HIV yourself, if you're comfortable, let your children know that you have HIV, because you might be saving their lives by just disclosing your status to them. And I want to thank you guys for including me in that.
Thank you. For me, when I first was asked to do this, I saw it as an opportunity to put my story out there and to be at help with other, peers that are living with this condition. I understand the challenge to come out and share this condition. However, with me, it was easier because a member of the family outs me at a wedding with 200 people. I mean, it's there in my story. So it was very traumatic that weekend, but then it was easier because suddenly you have to tell anybody. Everybody knew. And that took care of my circle of friends became very smaller, but it was genuine. Until this day, they're my support group. But the challenge was I didn't realize that I could listen to my story, because it opened. I mean, I told my story from when I was little, because it's a story. So it took me months of Elia and Natalie sending me messages like, have you listened to it? Have you listened? Sometimes I will ignore them. Sometimes I will. And then finally, my son was someone who said, Mom, that's awesome, the story you're saying. And he just encouraged me. So after that, I sent a group message to all my family and friends, and the rest is history. And I feel more empowered. I feel that, hey, you know, it's open, it's out there. Now I know I can do it. And I'm very thankful for Natalie and Ellie and also my peers here that, you know, we encourage each other to do this, to be out there because, you know, it's a challenge among us women living with this condition out there, especially for minorities, like all of us are here. And add being a woman and everything else. So I encourage you to do this podcast. Let's put it out there and talk about it so we can end the stigma and prevent other women from, because, you know, it took almost 2 years for them to diagnose me. I was living with HIV. They diagnosed me with everything else because nobody really thought of doing a test because I didn't fit the criteria. And I was even diagnosed with lupus. That was the last diagnosis before I was diagnosed with HIV, is that. So also we need to educate the providers because that should be a routine test. It saved me so many hospitalizations. It would save me a lot of hospital visits and ER visits. So thank you.
Thank you, Edo. For me, you know, I haven't heard my story yet. I'm really eager to listening to it. It hasn't come out yet, but I'm really eager to hear myself. I mean, I'm in a book, but it's not the same. So I'm really eager to see, like, I keep continue listening to the podcast, like hoping that, it's already there, but it hasn't come out yet. So can tell you how I would feel, but I mean, I'm really excited to like I said, I'm waiting to hear it and see, like, I don't know, I like to hear myself a lot, so I think I'm gonna sound great. If I don't say who will.
I love that. I think, again, everybody's reaction to signing up, you know, some might be hesitant. I think that was really our struggle in the first season. It was much more difficult in season 1 and 2 to get women to participate in this. Again, a lot of begging, a lot of, you know, the social work following up. But then after it got some traction and after we were able to partner with Prestige Place in San Diego, we've partnered with other agencies as well to identify women who were ready to tell their stories. So I'm going to ask Elia to come up and share just the evaluation process to assess when they're ready and identifying participants.
So as Natalie was talking about how the first the vision came out at the beginning, and it was kind of like, what do we gather some women and you know, interview them and do A, Y, and C and blah, blah, blah. And I was like, oh my God, who I'm going to invite? Because, you know, a lot of the women, we had to have a lot of this in terms of take account what was happening with their living situation, where they were living out, who knew, who didn't know, how, you know, they come to see it. How we started was in our clinic, and who was coming like more with family and less with family. You know, were they going to go back to some traumatic situations, and how was going to be able to be there for them? Because were they going to have food to get there? Were they going to have, you know, taxi connection with them? Being able to kind of you know, be honest about what we were looking at in terms of asking them questions. Not had you know, jot down all the questions, which was great. I didn't have to come up with anything like that. But they were, you know, they were questions that were going to touch a lot of these subjects that we trying to put it on the side. We trying to kind of shove it down and not talk about it so much. As you know, therefore, it was. I usually would call them. I asked one of them, my first. I wouldn't say victim, but she wasn't my victim. I was Marilyn. I said, hey, you know, because she always participated in the cabs that we were doing, and if there wasn't a little event, she would come, and you know, the way you start carrying yourself, sometimes they gives you more clues, right? So then, and I said, well, she says that she gets because she has kids. I said, she says it because of the kids. I'll watch the kids. Because she doesn't say, I will give her that. Because it didn't. You know, we're here because, you know, your boss challenged you to kind of step up to your plate in a way. So I was like, oh my God, if they, like today, for example, we had 7 women and they were all ready and all that to come. And I picked up one in the morning, never came out. So you have to just move on. If it does, you cannot come, that's fine. The same thing with a podcast. My role is to make sure they're ready and make sure they're happy with them. They don't know what happens in between that. So, all that begging, all that texting, and then I forget to text people. It's like,
She needs a raise.
So it's stuff like that, you need to take a time. You need to be very flexible. You need to be very, yourself. Be yourself, not try to fake anything, because they're going to be themselves and they're going to open up to really, I haven't heard myself. When they say, can you review that recording? I'm like, no, I don't want to. I don't want to hear myself too. I get that, and now that when they're talking about something so deep into them, the stigma themselves, all this stuff that goes through them. So it was difficult. What was the other question that you asked? That was it. You see, I can talk forever. Anyway. I tried to let them talk. I did interview some of them. We were kind of ready with some of them were like, because we trust you guys. You guys collaborate within the partners. So I wasn't like, okay, we will interview them. And then they can tell us what is it, our interview when we were interviewing.
Yeah. So I was going to say that when you listen to their episodes, it's really their full life story. It's not just their HIV story.
Right.
And so it really goes to childhood, their upbringing, to their diagnosis, to after the diagnosis, really getting you up to date to where they're at today. And so just want to go back to the panelists and ask what part of your story was kind of hardest to dig into? Because again, it's asking your whole life, basically.
They knew what we were going to ask.
No, we don't share because we don't want people to rehearse. To rehearse. We want it to be authentic. We want it to come out naturally. And that process has really worked as far as getting authentic storytelling.
For me, I was really excited about it. I always get super nervous, of course. I think that's normal. But I think when it always gets hard to, is when they ask me about my support system. Because when they gave me my diagnosis, in my mind I was like, okay, my mom is who's gonna make me stronger, or who's gonna, for me, it's gonna be my breaking point. Which is funny that I thought about that, because she's always been there for me. So I think once I get to that point is when I get really emotional, because I knew that was gonna be my point to either embrace it and embrace it. How would you say it in English? Abrázalo, acéptalo. Embrace it, accept it, and run with it. And so I think that's when it hits me the most, when I have to say that little part. So I think once she hears that, she's gonna be crying a lot. Yeah.
That's good.
We like emotions.
Thank you.
And for me, it was the HIV. It was the trauma that I lived growing up.
Yeah.
That was a challenge. Because, it's in the podcast, I was sexually abused as a 3, 4, 5-year-old. And reliving that, and especially that my son didn't know pretty much. I mean, he had a vague idea, but yeah, he had a lot of questions about it. So that was but I'm glad that I did it, because it set me free, and it changed, it took away anxiety from me now. That I still have sometimes, but I mean, it's not as bad as before. So that was my challenge, my trauma growing up.
For me, obviously, it was, talking about my son, and also growing up, the trauma of things that I went through growing up. But mainly it was the part, like I said, talking about my son, because it's something that I have not quite been able to talk a lot about. So, that was the hard part for me.
I think I also, I don't think it was the HIV diagnosis. It most was dealing with my father's death and being pregnant, and just all the trauma that came with it. Why am I even here right now? Everything, growing up, not having a mom, growing up with the trauma just that came from childhood more than the HIV. And then my father's passing, I think that's the only part where I get emotional, is where my father didn't know I was positive. And I didn't even tell him I was pregnant because I thought he was going to kill me. And I was 19 years old when I was pregnant with my first daughter, but that's the hardest thing. I think that till this day, there's a lot of healing I still have to do with my father's passing and just the type of daughter I felt I was. And that's why my episode's called The Daughter's Journey, because that's what really hits me. I think that out of all the trauma I've had in my life, my father's death is the most. I don't talk about it. Like, I try to forget his birthday and stuff like that because I just don't want to think about it.
Right, thank you. So my next question I didn't ask last time, but I'm going to ask this time, is what did you guys do for self-care either after, recording your episode or after listening to your episode? Because I think that's really important, is, reliving, like, again, maybe reliving some of the trauma, but then going back to take care of yourself.
A lot of crying. A lot of crying, releasing it, listening to positive things. I like to listen sometimes to, positive music or positive phrases. That's just letting it all out.
For me, it's interesting because I didn't cry. I was really excited to tell my partner and my mom about it. So I was like on my way home and I was just like, oh my God, good job. You did so good. Oh my God, you are so great. It's funny, but that's the reality. I was just like, so when I think about the diagnosis and everything, I don't take it as oh my God, why me? Why? If anything, I thank God for giving me the strength to embrace it and educate myself. And so therefore, it like you guys mentioned it before, it's a new purpose. So I think that's what I wanna get out of it and just be positive. But then again, I haven't heard my story yet. So I might, once I listen to it, I might be oh. So yes, I'll keep you guys posted.
For me, when I first did the podcast, I was like, oh, okay, I did a podcast. Okay. It really didn't hit me until I heard myself.
Mm-hmm.
And so after I heard myself, after I cried and it was happy cries and all the emotions and things, I actually sat down and watched a movie that me and my son used to watch together because I had not had the heart or the nerve to even watch this particular movie. So it was a movie called ATO. We used to sit watching together. So to be able to do that, afterwards, so I actually celebrated after I heard it, after I cried and had all the emotions.
I cried and I think I just buried myself in my bed for a little bit. I like to sit in my bathtub also and just cry in there. That's what I do to get, some time by myself because I have 5 kids and a husband that's really needy is sitting back there. And every day it's like I can't, there's no time to be depressed, there's no time to be sad, it's just go, like the kids are hungry, I gotta do this, I gotta do that. And so that day I was just like, you know what, I'm just not even gonna get up, I'm just gonna lay here and soak in the bathtub. And that's what helped me, honestly, because it's really extremely hard for me. And it shows, telling my story, that it's really hard for me to feel my feelings. I do not want to feel. And so a lot of the coping mechanisms that goes with using and just avoiding everything but feeling, I just allowed myself to feel sad and depressed and angry, and just I allowed myself to feel that. And thankfully I have Elia that I can text and call at every hour of the night. She's like, I'm fine, I'm not sleepy. I'm like, okay. Oh, don't tell her boss. Okay, good. So I'm
seen her too.
Yeah, I'm thankful for Elia because crises don't happen from 9 to 5. I'm a mother, and my crisis happen at 9, 10 in the night when I'm allowed to have crisis when all the kids are asleep and I'm just freaking out. And I'm like, Elia, what do I do? Like, I want a divorce today. And tomorrow I'm like, no, I'm good. You know, we're all good. We're cool. But yeah, I think that support, having Elia and being able to talk to somebody about it, and then also the other people that participated. And for our first season, that I know most of the women that participated, just be able to call and be like, girl, what did I do? Like, why did I do this? And just being able to talk to each other. Our support group that we have with Elia, being able to share has been just fundamental to me when I didn't even like support groups. But now I do.
Now you do.
Yeah, now I do.
So these are our current season. Season 1 is focused on Latina women. Season 2 is Black African American women. Season 3 is our Spanish season. Season 4 is substance use and pregnancy and recovery. Season 5 is aging with HIV. Season 6 is our transgender season, and we include a transgender male who's part of the season. So we've been able to expand to include trans women. Season 7 is we partnered with Christie's Place, and we went across the border and recorded, I think, like 8 women from TJ. And I think that's the current season that we're in. Yes. Season 8, we're expanding to do PrEP, and so individuals who are on PrEP, cis males, trans females, cis female, trying to be inclusive as possible to let people know that PrEP is for anyone who is sexually active. And really, if we had those messages earlier, again, I don't think we would, again, say women are still, not being included in these conversations. And then our season 9 is about family members and addressing how family members are affected by HIV. 25, I think we're going to do a hero season of people who have been very impactful. So looking at providers, social workers to tell their stories of being part of the epidemic. And then 26 is my wish list of places I would like to record. And things I know, I'm trying to create a travel. So those are some ideas that we have to continue. Right now, we're a collection of about 30 stories of women living with HIV, and we're hoping to just, again, continue to build on this collection of stories. And so I'm going to ask one last question, is in your season, on your episode, was there something that you felt like you didn't get to share and that you would want to share?
In my first episode, yes. And I think that I covered it in the second episode in season 4. But I think that we always are evolving as humans, and that, once you hear something, you're like, oh, I should have said something different, or I should have said that, or I should have focused more on this. So I think that as we evolve as humans, we're going to find something else we should have said, more impactful, more empowering, more educating. But I feel like I told my story as me, and my mom was really upset at me because I told my story, my story. It's not her story. And she was like, I don't know why you even had to mention all that. And I was like, well, it's not your business. It's my story. She's like, well, that's not what happened. And I was like, well, again, it's my story, and I think I shared what I needed to share. And if you don't like it, well, then, oh well.
Your mom wants her own episode.
I think my mom wants her own episode. But yeah, we're not gonna give it to her. She can comment if she wants. But yeah, I think I told my story, and fortunately I got the second chance to do the second episode, which was talking more about being a mother and my substance use, and overcoming that and where I was at now. Because I was like raw, Marilyn, like just coming out, telling the world that she's HIV positive. And that was like the most raw version of me. And then the second episode was a more healing version of myself. And although I do get vulnerable of, pregnancy and having, feeling like HIV robbed me of some, moments of being a mother, it's not the case now. So, things are changing, and that was just my experience.
With me, I feel I said everything, like I said, but now that I'm sitting here thinking, because like you said, we're steady evolving. Right now that I'm sitting here thinking about it, I should have talked more about my substance abuse use and being homeless, because I literally have been homeless, sleeping in the park and in cars and stuff 4 times. And I didn't talk enough about that. Now that I think about it, I'm like, I should have talked about that more, because so many people have been through that too, and the substance abuse.
They need to listen to it and then give us their feedback.
Yes.
I don't think so, but yeah, they need to listen to it.
I mentioned it on there?
What?
Did I mention it on there? Oh, see? Yeah.
And for me, I mean, not that I didn't say what I didn't do. And like Marlon said, I vary my feelings. So I almost disconnected during the interview. I share everything, but it wasn't until I listened to it that I had my breakdown. So I don't know if it's because that's how I learned to cope. So I'm working on that because, you know, that's nothing like showing emotions. I think you even mentioned something earlier, like, well, tears, no. And I just couldn't. But it wasn't until I listened to it and oh boy, I cried the whole night. But I felt so much better when I woke up the next day. My eyes were red and everything, but I felt really. So that's what I did.
Oh, thank you, Vero. I think for me, it's funny because once I was done with the interview, I was like, oh my God, I didn't say the most important thing. Get tested. You don't need to I mean, even if you're married, ask your provider for a test, because it's really important to know your status. And it's funny because I kept saying, did I mention it? I don't think I did. And I was going back and forth. And I probably did, and I'm thinking that I didn't. But it's one of the reasons why I do what I do now. Because everybody that's sexually active can be at risk if you're not protecting yourself. So that's what I'm trying to put out there every time that I talk about my story. So till this day, I mean, till this moment, I'm like, did I say it or not? So I go back and forth. So that's why I'm really here. So listen to it and please let me know. Thank you.
So our podcast, we have about almost 7,000 views. Again, we can see where it's being listened to. So this is the U.S. We are also able to see city level. So after today's presentation, we hope we have a lot more for Palm Springs, Palm Desert, out in the.
We know.
Yeah, we know if you listened or not.
We're watching. We're monitoring.
Yes, we're constantly monitoring. And again, send it to other people. So now we're going to open up for any questions.
Anybody has a question?
I'm wondering, I'm sorry. I'm only 3 months into this, and my adult children all found out before me, actually, because I was in a coma and, blah, blah. But I need to talk to my grandson, and I'm just wondering if anybody had an experience like we're a fucked up family, everybody's high or drunk or whatever. I've been in recovery for 25 years and I'm still stupid because, but I don't know. I mean, I told him, believe me, every time I talk to him, Nico, if you're going to I don't care, you got a girlfriend. And of course he said, no, I'm too young, I believe in God, blah, 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 I'm Christian. I said, yes, so was I. But I'm just wondering, how I'm going to take he's moving from Laguna Beach to a recovery house in Arizona. So I'm going to have about 8 hours, just me and him in the car. So, if anybody had experience talking to the children, it doesn't have to be your grandchildren, but he's like my child. I caught him when he came out. I don't want to scare him, but I kind of do. I kind of do want to scare him, and I'm having trouble with some of my family. We have little babies, and even though they're in healthcare, I opened up a package of crackers or something. It wouldn't open. I used my teeth. My daughter lost her shit at the pool in front of like 100 people screaming at me. And I was like, you know, you don't catch it that way, and I'm undetectable already. So, you know, but anyway, that's why I came here. I came looking for people to share their experience with me, because I really, for all I know, I don't know, you know, and I need help. So, thanks.
I want to thank you for being so open. I want to thank you for being so open. I was talking to you earlier. We were talking, and that takes a lot of nerve just to be able to say that in this room. With disclosure, there is no right or wrong way to do it. There's no right or wrong time. It's when you're ready to disclose. And as far as what to say, she just said the podcast. You know, you might want to have the podcast played or something so he can kind of hear. Or ask him, you know, hey, what do you know about HIV? You know, just you can start off like that, you know, and then you can feed off of what his answers is, and then you will know if it's that time to disclose to him or not.
Yeah, they just got done with the sexual awareness,
Mhm.
because he just graduated 8th grade.
Okay.
And the last section was all about that, and that's what really got me like,
Mhm.
you know, because I was thinking, if I can, I just want him to know that he can talk. I mean, he knows he can talk to me about drugs,
Mhm.
about this, about that, about, you know, because we lived really open with
Mhm.
that. And he's lived the consequences of having heroin addicts as parents. And I just want him to know that this too, you can talk to me about.
The door is already open. Yeah, you just have to, like I said, you know, put it out there to him. You like I say, start by asking him, you know, hey, what do you know about this? You know, hey, you guys had this at school. What did they tell you guys? You know, you can start by educating him piece by piece until you are comfortable with letting him know about your status. Because that way you're still educating him, but you're still keeping yourself, keeping your mental state together until you're ready to actually say something, but you're still protecting him at the same time.
Yeah, and truth is really important to him.
Yes.
Like when his mom went into treatment this last time, I thought she had told him that his movements were good, and I didn't find out till we were halfway there that he had no idea what his movements were. He had to go live with my son and grandparents. So I'm really cognizant of being, you know, truthful. So I think he would probably ask me if I started talking about it. But I want to thank everybody in this room.
Thank you.
Out there, because I asked my doctor. I said, are there any women out here? 'Cause
Many,
it's all men.
many.
Plenty.
Yes.
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 I'm sorry.
So he said, come to this.
Thank you. We're gonna have to stop it because we're done with time. I run a support group. I just disclosed to like a 9-year-old, so I will approach you and help you whatever is possible. I'm in LA, but yeah. So and then Maryland is always available. I will go. Oh yeah. Sorry. Do we have a couple minutes? Oh, okay. I guess we do have 3 more minutes.
Okay, I'd like to say something
Yes, please do.
to her. I mean, just, yeah. Hi. You know, you can never go wrong being honest. And you could always use the podcast, play it. I mean, talk to him. And maybe you listen to them before and pick one that is not too heavy. And then that way he knows that, hey, there's a lot of us out here. We just don't, we're working on it to end the stigma. That's, I think, you can never go wrong with that. And also, I had the same, I think most of us went through what you went through with utensils and all that. I remember when I first was diagnosed, my daughter was worried about me kissing my grandchildren and all that. But it wasn't until my provider, I brought her to one of my appointments and explained to her. And you know, it's like, oh, so it's not Because they didn't, I don't think she got it from me because, I was newly diagnosed. I'm not a provider, but when it came to my specialist, she got it. And after that, no more. So that's when I think you can educate your daughter, be a provider, because, I think it will be more helpful. So.
And also, I wanted to also add to that. I feel like it's really important to go to support groups, educate yourself. So when you go back to tell them to disclose your status, you can also tell them, but I have learned this and this, or you can also start with that conversation. You know that HIV, the medication has come a long way, or U equals U. I mean, there's so much information that unfortunately some of us, and I'm speaking for myself, didn't know until I was positive. So then that's why now I like to do what I do, because I want to keep our community from getting to that point, not before it happens to you. So, I mean, that's what I will say. Support groups, anything that you can get your hands on, it would be great. Janisha is going to talk to you about the retreat that they do at Christie's Place every year. That was my first thing that I went to, and getting empowered by all the ladies that was there, listening to their stories. I was 3 months diagnosed when I went to my first retreat, and listening to their stories. Oh my God. I mean, look at me now. I'm like, I feel like so empowered. So I really like to invite you to get yourself in any support group and anything that you can get involved. Yes, and you're gonna be fine. You're gonna be fine.
Can I pop in real quick? Sorry.
Oh, yeah.
Can I pop in real quick? I would extend to you one of the best lessons for me. The way that you talk to yourself and the way that you feel about yourself reflects in how other people treat and talk to you. Right? And so that's why I'm saying it. That's exactly why I'm saying it. There is a huge difference between telling someone, I have HIV, and I understand if you're scared and you don't have to continue to deal with me. And I'm living with HIV. These are the facts. I can answer any questions that you may have, right? So the more you deal with internalized stigma and get comfortable with yourself and recognize you're still you. You just got company that follows you everywhere you go.
Yes.
Right?
Yes. Yes.
And if you need some more empowerment, Bridget is in season 2. You can find her.
Yay!
So a round of applause to our panelists. Thank you so much for joining.
I just wanted to say something very quickly. You said your grandson is in 8th grade? Okay, I also have twins that are in 8th grade going into high school. I really want to just, you shared that he really appreciates truth, like being truthful. And I think that you should run with that. And for me, when I disclosed to my children, they were really worried about, are you going to die? And so just making him feel comfortable and, assuring him that you're going to take care of yourself and that you're going to be here, you're still grandma, and that nothing in this world HIV is not going to take you from this world. It's not, and just letting him know that you will take care of yourself and you're going to be here for him. I think that as my children, and one of my children is back there, that's what really, 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 really kind of sticks in their head. Are you going to die? And we know that we don't die from HIV nowadays. If we take care of ourselves, we can live a healthy, long life. And so I think that you can run with that. Be truthful to him, be honest, and let him know that you will still be here.
And I just want to add one thing real quick. And for yourself, always remember that it's a journey that you're on. But as we always say, and I know we say this all the time, HIV is going to become the least of your worries. It's going to become the least of it. There are sometimes that I even forget I even have HIV because of all the other things, I have in my life going on. So let that be your empower, to know that, okay, as time goes on, this is going to get easier for me. I'm still going to be here. You know, you're going to see your grandson graduate high school. You're going to be here, and let him know that, you know, like, oh, she left out. Like Bridget was saying, you know, when you're saying these things, people actually pick up on how you see yourself. And so, you know, always make sure that you are educating yourself, because that's what I found that helped me a lot, was educating myself. It took away the fear. It helped me with the internal stigma that I was going through. You're going to be okay. There's a village of women. You don't have to actually be there physically. We have the internet now. We have phone, you know, so you're not alone.
All right. So when I was in nursing school, I had an instructor who was from the islands, Mr. G. Mr. G was one of those people that always had energy, right? Was always going, always big, like bigger than life. And his favorite thing to say after every class was, "Okay, children, did you learn something today?" So did you all learn something today? Okay. I want to reflect on a couple of things that I heard throughout the day that I think are worth highlighting and reiterating. All right. So starting with, does everyone in this room know what, because a lot of people said it. Does everyone in this room know what U equals U stands for? And it's okay to say no. Right? And you said I do now. And that's common. So undetectable is untransmissible. If you are on your medication, have been on your medication for at least 6 months, and your viral load is undetectable, you cannot pass your virus sexually to another partner. What I want to highlight is that we tend to, as clinicians, as nurses, as healthcare providers, doctors, peer navigators, particularly in the era of U equals U, we stress being undetectable, right? And how important it is to be undetectable. But what I need each of you to recognize, and whether it is you or someone that you know or love, your viral load is not equal to your value. So if you are not undetectable, that does not detract from your value. It does not detract from the way in which you live your life with HIV, right? It means you're healthier, fabulous. It means you can have all of the sex that you want to have. But guess what? I have all of the sex that I wanted to have even before I was undetectable. So U equals U, great. But viral load does not equal value. Okay, so that's important. Portia said something that made me think. She was talking about having healthy sex, which wasn't pleasurable sex. So I stress to you that healthy does not equal pleasurable, but pleasurable can absolutely equal healthy. And whether you are living with HIV or not, you deserve to have pleasurable sex. And so there are conversations that, right, exactly. There are conversations that you can have around pleasure, because the other thing that gets understated about pleasure is empowering. Pleasure bolsters your ability to enjoy life. Pleasure releases endorphins and things in your body that make it easier to deal with stress. Pleasure involves connection and getting together, right? So all of those things are important to your overall well-being. So when folks talk about healthy sex, it's not just about the sex. It is about all of the emotions and things that underline that give you additional tools to be able to move forward and enjoy life and thrive living with HIV. Resilience. Miriam talked about resilience. I have a mixed relationship with resilience, right? Because resilience is a wonderful thing, and being able to bolster that and lean on those things to get you through the tough times are absolutely important. It's critical. It's amazing. But as a Black woman aging and living with HIV, I'm sick and tired of being resilient. What I want to do and what I want to focus my life on is speaking out and calling out the systems that require me to be resilient, and starting to change those things so that I don't have to rely on being resilient so much. So absolutely bolster the things and make the thing, focus on the things that give you resilience and that get you to the next moment, but also call those things out so that you can start to change those structures, whether those are structural, institutional, racism, political, or if those are things that you have going on in your life that you need to revamp and rearrange.
And then lastly,
we were talking about possibilities, right? When Carla gave her talk as part of the poem by Mary Bowman. Possibilities are endless, and your capacity to find possibilities and ways to live your life are endless as well.